As you can see, only a small amount of tooth structure is remaining, and extreme care needs to be taken not to damage the adjacent porcelain crowns. Either a periotome, scalpel, or luxator can be used to loosen the root for removal. In this case, I elected to use a luxator with a firm apical force between the root and the socket wall. It is helpful to use a small rotational movement with the firm apical force. Time is taken with this technique to apply the apical rotational force on the mesial, distal, and lingual sides of the root. This will cause blood to engorge the socket and help loosen the root for easy removal with an extraction forceps. After removal, the walls are thoroughly curetted to remove any periodontal ligament fibers, and the socket is irrigated with Paradex. I now determine which size, length of implant, and where I must begin the osteotomy to establish implant platform position. I developed the Verbin depth gauge to aid in the visualization of the final platform position prior to any drilling. Many clinicians prefer to use bone-level implants in the anterior region with platform switching. This gauge is also helpful with those implant systems. The gauge is a threaded 2.2 probe with a thread left off to indicate 6, 8, 10, 12, and 14 millimeter depths. There are 3 interchangeable collars which can be rotated up and down the probe. The collars are the exact size of the polished platforms of the implant I use: 1.8 millimeters in height, 3.5, 4.8, and 6.5 millimeters in diameter. The probe is inserted into the socket to the apex, and the collar is rotated to the ideal platform position, taking the tissue height and the adjacent teeth into consideration. Ideally, the platform should be 3 millimeters apical to the adjacent teeth CEJ. The probe is then removed with the collar in the ideal platform position. The length of the socket is determined. In this case, there was 10 millimeters of socket depth to the apex with ideal platform position. The Verbin depth gauge will allow me to determine the socket depth, ideal platform position, diameter of the implant platform, maintaining the needed distance to the adjacent teeth before starting the osteotomy. X-ray evaluation confirmed sufficient bone to place a 14 millimeter implant, which would allow 4 millimeters of bone for primary stability and have my platform at the proper vertical dimension. To maintain 2 millimeters of distance between the implant and the labial plate, the curvature of the premaxilla does not allow following the apex of the osteotomy. You must begin drilling on the lingual slope of the socket wall, which is difficult. To prevent the walking of the drill on the slope of the socket, a purchase point must be established first. Either a round burr or a liniment burr can be used to establish a point to begin drilling in which the drill can be controlled. We begin by first establishing the purchase point with a round burr. A 2.2 millimeter drill is then used. I like to use extremely low drilling speed, which allows greater control and direction of the osteotomy. The Verbin depth gauge is then placed to determine the platform position before proceeding to the next drill. Adjustments can be made if needed. I determined that I will use a 14 millimeter implant in this case. I will usually drill 1 to 2 millimeters deeper to allow me some wiggle room in placement. The 2.8 drill is then used, followed by a bone tap. I find that if I tap the site, it is much easier to get the implant started. If you were to use a self-tapping implant, then you can eliminate this step. The socket is irrigated, and then I place grafton into the socket before placement of the implant and try to lightly condense the grafton against the labial plate. I like to use a motorized placement of the implant, for it allows me a greater directional control. I will usually finish the placement with a torque wrench to determine the amount of insertion torque. As you can see, very nice stability has been achieved even with a 3.3 millimeter diameter implant. The healing abutment is then placed, followed by X-ray evaluation. An Essex retainer will then be used for temporization. Note the excellent tissue response at 4 weeks. At 12 weeks post-surgery, the healing cuff is removed and an open tray impression is taken. The healing cuff is replaced and the patient is dismissed. Following the impression, a soft tissue model is fabricated using a ESPE polyether material. I like to use the polyether material because it will not adhere to the impression and is also rigid and less likely to tear than some of the other mass materials on the market. After injecting the ESP material around the analog, a moist cotton pellet can be used to shape the material, allowed to set, and then a stone model is poured. From here, the case will be sent to the laboratory for crown fabrication. In this particular case, due to the limited space and clearance, a screw retained crown is fabricated. After adjustments are made to the crown will be torqued to place. Prior to torquing to place, X-ray evaluation to verify fit and seating the crown is taken. The crown is torqued to place and the screw access is closed. Patients appreciate the immediate single-stage approach, which reduces appointments, saves time, and speeds up the completion of the case.